Hello, dear participants. Last session of the day, oral presentations. We're going to finish up today. Robert KLAMROTH, he's very sorry. He will not be able to participate. So I'll be moderating the session. 5 different oral presentations. Canan ALBAYRAK will have 2 presentations. So she's going to do these consecutively. For the first one, to the podium, please. Real-world evidence from compassionate use program of EHL, Visium protein, efmoroctocog alfa in prophylaxis and treatment of bleeding in patients with hemophilia A. Distinguished participants, I wanted to present in Turkish because we have more audience, but my slides will be in English. So I think we have translation. This trial is real-world data. For the first time, for a long-acting factor, we had this use period. 8 different centers used a center, efmoroctocog alfa, recombinant Fc fusion protein product. Human aid, early accession program. To be licensed, companies who had applied to the ministry wanted to start an early reach program for humanitarian purposes in 8 different centers. 8 different patients started using this product. Hemophilia A is a rare inherited bleeding disorder that results from factor VIII deficiency. It's a disease that characteristically manifests with hemothrosis and hematoma. Main treatment is replacing factor VIII. What we call critical level. They frequently go beyond that, and as the time here extends, we have extra spontaneous bleeding from patients. Long-acting factors, when we inject them with the same frequency, we see that we have gone above the critical level and that patients do not spend a long time in those low values and they experience less bleeding. If a long-acting factor is injected less frequently, this time we are reducing infusion frequency. Of course, the aim is to go above the critical level. Efmoroctocog alfa is a recombinant factor VIII. Fc fusion protein has extended half-life. Half-life is 14 to 24 hours. And the first extended half-life recombinant factor VIII was approved in Europe. First time licensed. Fc fusion technology extended the half-life of the product. Neonatal Fc receptors are very important here. Immune globulin or other Fc-containing proteins, they bind the neonatal Fc receptors and they're taken inside the cell, and inside the cell they're protected from lysosomal degradation and they go back into circulation. So its impact on extending the short life continues like this. About this product, when we look at the prophylactic work, there are different doses, different administrations, 65 units per kilogram once a week. First day, 25 units per kilogram, 50 unit kilograms by the 4th day. There are very different administrations of the drug. Our aim in this study was to evaluate the use of an extended half-life recombinant factor VIII product. We wanted real-life data from this, an early humanitarian outreach program. With that, in 8 different centers, 8 different patients started using this product, and we wanted to wrap up the data here. Method-wise, the product is brought by the company, and patients started using those. We closely followed up on these patients. We checked for side effects, whether or not they needed additional doses for bleeding. And as method, annual number of bleeds, factor consumption amount, weekly infusion. Especially, we wanted to obtain these as data. Also, after the patients use this for a certain period of time, short form 36 health survey questionnaire scores of patients were recorded to see whether or not there's been a change in quality of life. When we look at our results, in fact, 8 centers participated, I said, but we couldn't use the data in one center because the patient was non-adherent, it was understood. So those data were canceled, total of 7 patients. All patients were male, and the median age was 11, between 57 years of age. Very heterogeneous age, and the clinics of the patients were very heterogeneous because there were mental retardation patients, chronic coronary artery patients. We had a wide variety of patients, no hemophilia history, and median factor 8 levels was below 1%. Severe hemophilia patients. 5 patients had a history of significant, again, a history of surgery, and there was a target joint problem in all 4 patients. Generally, for more than 1 year, the patients were using this product, and when we look at the clinical findings of these patients, the weights were very low to 88 kilograms, and in all 6 patients, knee, ankle, elbow were the target elbows. Who administered the infusion? One said self-infusion, 2 mothers, 1 father, and 2 patients were injected by nurses. Times of infusion were important. Time of the day. Were they in the morning or later on in the day? That was also important. And here, all 4 patients took their infusions in the morning. The others were variable. Okay. Yes. 40, 117 international unit, median 70 international units. Change in the dose later on, yes, in 86% of our patients, we needed to change the dose. Less frequent doses were administered. Median was 0.75, in fact, below 1. Annual factor consumption was quite variable at best. Quality of life of our patients, to measure those psychological, physical, social functions, and pain functions were assessed. All of them, compared with the previous years, had very good quality of life. Apart from that, these products, their impact on annual bleeding time and infusion per week, when we looked at those, when we looked at the previous practices, there was pronounced reduction of annual bleeding rates. Factor consumption was reduced. The numbers of infusions came down from an average of 3 infusions to 1 single infusion. And in this picture here, number of clinical bleedings had been reduced by 71%. Weekly factor consumption had reduced by 33%. Number of weekly infusions had been reduced by 76%. There was no inhibitor development, and no significant adverse effects were reported as a result. This is the first long-acting factor real-life data trial. It's very important. And we saw that a long-acting factor product could decrease the number of weekly infusions, and also clinically and as quality of life, there was significant improvement in figures. Of course, these types of trials should be performed on a wider range of patients. Having said this, I would like to thank our patients and their families for participating. I would like to thank the clinicians for their work, and I would like to thank Sobi for their support in the procurement of the products. For over a year, these patients were not reimbursed. They are using these products totally free of charge, and financially they have supported the country. Thank you. Thank you, Professor Canan. Any questions I could take from the hall? Well, thinking of questions, Dr. Prasad Matthew. Buraya gelir misiniz lütfen, doktor? He's going to ask a question, Dr. Matthew. PAP hastası var mıydı? Hayır, yoktu. Lütfen buraya gelebilir misiniz? Paylaşalım. Sizi davet etmek istiyorum buraya. Evet, lütfen. Dr. Albert Klamroth gelemiyor. Onun için bu oturumu beraber yönetebiliriz. Presentation. Those of you who'd like to ask online, a small warning. Please ask your questions online. I can see from here. Second presentation, bleeding disorders, single center results. Distinguished chair, distinguished participants, on to my second presentation. There was female patients with hereditary bleeding disorders, single center, because hereditary bleeding disorder female patients is whom I'd like to present. Female bleed patients, in fact, are very important because among the public, sometimes among the physicians as well, there's a misperception. It says if bleeding disorders are male disorders because hemophilia A's and B's are generally male patients. There's that awareness, whereas female patients are thus being ignored, and they need to have an early diagnosis, and they should not be neglected in benefiting from treatment. So, May 19th, Hemophilia Association stand. We try to draw attention to female bleedings. And in this whole presentation, I would like to reinforce this. Now, when we look around the world, for each and every hemophilia patient, approximately 5 potential carriers. And actual ones are 1.5 actual carriers in hemophilia, and 0.5 are bleeding hemophilia carrier patients. Hemophilia carrier, is this a finding that needs to be found? Are they bleeding? Really, hemophilia carriers, in 1/3 of them, factor levels are below 40%. We see this to be the case in the clinic as well, and 1/3 of those have abnormal bleeding experiences. And which bleedings? Heavy menstrual bleedings, postpartum hemorrhages are the most frequently encountered types of bleeding. Also, these individuals in the future, when they're having children, they are likely to give birth to hemophilia patients, potentially. So they should be determined right away, detected right away. These bleeding disorders, what is the impact on women and girls? Pain during periods, adverse psychosocial effects, and of course, time lost from work or school in the case of these patients because they have excessive bleedings, they need large pads. So therefore, during that period, They may not be able to go to work or to school, these patients, and they are subject to unnecessary procedures. Sometimes post-procedural, they have severe bleedings, and there's always anemia, iron deficiency in their lives, sometimes hospitalizations, and there's maternal mortality, and quality of life is reduced, of course, and their daily activities are always limited. And when we look at it, female patients with bleeding disorders, they're always diagnosed late because hemophilia is always thought to be suitable for males. Severe and moderate hemophilia patients, those females are diagnosed later. In severe ones, 6.5 months, and for moderate, 39 months is the period of delay for late diagnosis. And even mild ones are diagnosed 6 years late. Our aim in this study was European Hemophilia Comprehensive Care Center. We have the certification as a unit, so we wanted to see the distribution of female patients with hereditary bleeding disorder. And in this group, hereditary bleeding group, female patients, 332. And when we looked at the distribution, which ones do we see most frequently? Hemophilia A, 2 patients. Carrier of hemophilia A, 74 patients. Carrier of hemophilia B, 20 patients. Von Willebrand disease type 1, 20 patients. Von Willebrand disease type 2, 6 patients. And type 3, 10 patients. Of fibrinogenemia, 2 patients. Hypofibrinogenemia, 10 patients. Factor V deficiency, 3 patients. Factor 10 deficiency, 3 patients. Factor 11 deficiency, very widespread in our region. Severe and mild types, 126 registered ones, all female. Factor 13 deficiency, 3 patients. Factor 7 deficiency, again seen frequently, 36 patients. Factor 5 and 8 deficiency, 3 patients. Glanzmann thrombasthenia, frequently encountered in our country, 7 patients. Bernard-Suller, 2 patients. MYH9 disorder, macrothrombocytopenia, 4 female patients. Gray platelet syndrome, 1 patient. Now, in general, when we look at our patients, most frequently factor 11 deficiency was seen at 38% of our female population. This has to do with the frequency in our region. In the Black Sea region, it is frequent. Hemophilia A carriers, again, 22%. Factor 7 deficiency, 11%. Total von Willebrand diseases, 11%. Hemophilia B carriers, 6%. 2 of our female patients were patients with mild hemophilia A. They carried a compound heterozygous mutation. Their fathers were sick and mothers had factor 8 gene mutation, compound heterozygous. So the 2 genes coming together, the patients became hemophiliac. Again, autosomal recessive rare factor deficiency. These also were widespread. These were male and female equally observed. We also had inherited platelet dysfunction, mostly autosomal recessive, but there were dominant types as well in male and female patients. As a result, the bleedings in the case of women are as important as the bleedings in men. That's what we wanted to draw attention, especially carriers should be detected and the required treatments should be given to them. They should be cared for during pregnancy. The potential should not be ignored, and necessary treatments, prophylaxis, should be administered to those people, and they should not be made to suffer. As far as clinicians are concerned, bleeding diseases, it does not only happen in the case of men. Female patients are also worthy of attention. They should not be neglected. Good history should be taken, physical examination, lab tests, so that patients can be diagnosed earlier on. That's what I wanted to underline. So I could really skip those. We can increase their quality of life. Lastly, about bleeding women in Turkey, we have projects that are ongoing. We wanted to start with this first, and in the stand of May 19th Hemophilia Association, we wanted to draw attention to female bleedings, but this will continue, and we want to present data that covers the entire country. Thank you very much. Thank you. If you have a question, we can take.
Dr. Matthews wants to ask a question. Açıkçası bölgenizde faktör 11 eksikliği hastalarının sayısını görünce şaşırdım. Acaba Yahudi popülasyonu var mı bu bölgede? Aşkenaziler arasında çok yaygın çünkü. For years, we had a lot of factor 11 deficiency syndromes, disorders, but we wanted to, do some genetic research on that to present it. Yes, there are different mutations in Turkey which does not exist in Ashkenazi Jews. And I used to ask certain patients, whether they were Jewish, but they said, no, we are Turks, and when we worked on their genetic structure, they were not Ashkenazi, and, our patients had a different type of mutation, and we will be presenting them and publishing them soon. We have 250 patients, and in about 100 of them, we have worked on the mutations, studied the mutations. There are some double mutations as well. We'll be publishing them soon. Factor 11 deficiency is not only common among the Ashkenazi, but it is also very common in the Black Sea region of Turkey. So we are going to document that as well. Thank you, Canan. Any questions? No online questions. Factor 11 prevalence is quite high in your region. It's really surprising. Yes, that's autosomal recessive. Yeah, and Professor Matthews was surprised as well. Yes, there is kinship, and in the Black Sea region, marriage amongst kins is quite common. That's why maybe. Another question. Hipofibrinojenemi hastası olan hastalarda tromboz gelişti mi acaba taze donmuş plazma ürünleriyle bağlantılı olarak? We do not have many patients like that. Afibrinogemia is little. We don't have severe bleeding in them in thrombosis since they have hypofibrinogemia. They can still carry on with their lives. We have only one female patient, and there is no significant bleeding because she's young. Thank you. Dr. Matthews, it's your turn. Bir sonraki konuşmacımız Doktor Ergül Berber. Kendisi hemofili B hastalarında somatik mozaiklik konusundan bahsedecek. Kendisi bir araştırmacıdır. Bütün hayatını laboratuvarda ya da hayatının büyük bir kısmını laboratuvarda geçirmiştir. Başkalarıyla ama tanışmayı, konuşmayı da çok sever. Bakalım neler söyleyecek Ergül. Buyurun. Teşekkürler Sayın Başkan. Ben sizlere primer verilerimizi paylaşacağım. Araştırma projemizde elde ettiğimiz hemofili B hastalarını faktör 9G mutasyonu için inceledik ve hemofili B veri tabanı üzerinden incelemeler yaptık. Bildiğiniz üzere hemofili B X bağlantılı resesif bir kanama hastalığı faktör 9 gen mutasyonlarıyla asosiyedir. Faktör 9 geni X kromozomunun şundadır, 34 kilobaz bölgesindedir. Faktör 9 geni vitamin K bağımlı serin proteaz F9'unu kodlar. Bu faktör 9 da hemostazın içsel yolağında etkilidir. Ona katılır. F9 geni 8 ekson 7 intron içerir. Ve bunlar da faktör 9 genini belli yapısal bölgelere ayırır. Örneğin exon 2, 3, 4 ve 5 özellikle IGF-1 ve 2 alanlarıdır. 6 ve 8 de serin proteaz bölgesine etki eder. 12 Eylül 2021 tarihi itibariyle toplam 1347 mutasyon bildirilmiştir insan gen mutasyonu veri tabanına. Bunların büyük bir kısmı tekli nükleotit kameleridir. Pointer çalışıyor mu acaba? Peki. Yani takip etmek güç aslında biraz bunu. Tamam, şimdi gördüm imleci. Gördüğünüz gibi bu mutasyonların büyük bir kısmı tekli nükleotit kameleri, nonsens ve missense ile bağlantılı bilhassa. Burada amaç F9 hemofili B hastalarında Türkiye'de F9 genine ilgili tarama yapmak, gen varyasyonları ile ilgili ve ulusal bir veri tabanı kurmak. Bu amaçla hastalardan tükürük örnekleri aldık. Çünkü bu non-invazif ve basit bir yoludur DNA almanın hemofili hastalarından. 450 kayıtlı hemofili B hastasını bu çalışmaya dahil etmeyi hedefledik. Öncelikle tükürük numunelerinden DNA izolasyonu gerçekleştirdik ve ardından yüksek çözünürlüklü etme analiziyle HRM ile post PCR analizi yöntemidir. F9 genini analiz etmeye çalıştık. Böylece erime sıcaklıklarında PCR ürünlerinin farklılıklarını, varyasyonlarını tespit etmeye çalıştık. Şüpheli F9 gen varyasyonları HRM ile tespit edildikten sonra teyit edildi ve DNA analizine tabi tutuldu. Hemofili B hastalarından tükürük numuneleri almak için 10 merkezle irtibata geçtik. 6 merkezden 101 hastadan tükürük numunesi alındı. Bunlardan 5 tanesi kadındı. Hastaların 55 tanesi İstanbul'dan, 14 tanesi Gaziantep'ten, 11 tanesi İzmir'den olmak üzere tükürük numuneleri alındı. 101 hastadan 82'sinin klinik tanısı bildirildi. Bunlardan 40 tanesi ciddi seviyede etkilenmişti. 15'i hafif, 27'si de orta seviyede etkilenmişti bu bozukluktan. Öncelikle faktör 9 gen analizini HRM ile birlikte optimize ettik. Bu amaçla ekson 6 ve 8'in sayısı çok olduğu için F9 genini 13 bölgeye böldük, alt bölgeye böldük ve HRM analizi gerçekleştirdik. Faktör 9 gen varyasyonu olan hastaları tespit etmek amacıyla bu analizi yaptık. Burada bir örnek görebiliyorsunuz. HRM analizi ile ilgili olarak bir hastada varyasyonu bize gösteriyor. Erime sıcaklıklarını sağlıklı bir hastadaki faktör 9 geniyle karşılaştırdık. Sarı eğri hastanın faktör 9 geni, mavi ise sağlıklı kişinin faktör 9 geninin erime sıcaklığı. Mutasyonları doğrudan DNA sekanslamasıyla tespit ettik. ...31 hastada faktör 9 gen varyasyonu tespit ettik. 6 tanesi heterozigottu, bir tane de yeni mutasyon tespit ettik. Mutasyon tespit ettiğimiz hastaların listesini görüyorsunuz. Burada da görebileceğiniz üzere 6 tanesi heterozigottu. Bunların hepsi erkekti. burada da yeni faktör 9 gen mutasyonu görülen hastaları görebiliyorsunuz ve misens mutasyonunu görebiliyorsunuz. Asparagin lisinle birlikte burada proteinde bunu görebiliyorsunuz. Öncelikle bu yeni varyasyonun patojenik bir varyasyon olup olmadığını değerlendirdik. Polifen analizi yaptık bu amaçla. Bu analiz neticesinde muhtemelen hasar verici, zarar verici bir mutasyon olduğu ortaya çıktı. Erkek hastaları heterozigot olarak tespit ettiğimiz için genotiplemesini görmek istedik bu hastaların DNA'sını ve akgüvar hücrelerinden izole edilmiş DNA sekanslama analizi gerçekleştirdik. Bunları bu hastalar için görebiliyorsunuz. Tükürükten izole edilen ve akgüvardan izole edilenleri görebiliyorsunuz. Bakın buradaki pozisyonda çift pik var. Ancak akgüvardaki faktör 9 geni heterozigot değil. Dolayısıyla da burada da bir alel yok. Bu pozisyonda olduğunu görüyoruz. Bu ise başka bir hasta HB32. Burada da yine çift pik var bakın. Akgüvar faktör 9 geni ise heterozigot değil ve bu hasta da durum bu şekilde gerçekleşmiş. Şu ana kadar ilk verilerimiz bize şunu gösteriyor. 31 hastada faktör 9 gen varyantı tespit ettik. 14 hastada 11 farklı misens mutasyonu tespit ettik. 5 hastada ise 3 farklı nonsens mutasyonu tespit ettik. Bir hastada bir küçük delesyon, bir hastada bir splice alanı mutasyonu ve bir hastada da bir SNV tespit ettik. Bu varyasyonların %65'i serin proteaz kodlayan egzonlardaydı. Ve daha önce de söylediğim gibi bu yeni varyasyon asparagin lisin varyasyonu analizde muhtemelen zarar verici, hasar verici bir varyasyon olarak tespit edildi. F9'un iki farklı dokudan sekanslamasında somatik mozaiklik ortaya kondu. Farklı genotipleri sahip bir bireyde iki veya daha fazla hücre hattında olduğu tespit edildi. Farklı embriyolojik kökenlerden elde edilen hücre tiplerinde somatik mozaiklik ortaya çıktı. Ektodermden ve endodermden kaynaklanan oral kavitede epitelyal dokuda bunlar tespit edildi. Ve mezodermden kaynaklanan kan hücrelerinde görüldü. Somatik mozaiklik ya meyozis esnasında ortaya çıkan bir mutasyondan kaynaklanıyor. Annede fertilizasyon öncesinde düzelmemiş. Ya da implantasyondan önce zigotta ilk mitoz bölünmeler esnasında bir postreplikasyon onarım hatasından kaynaklanıyor. F9 geniyle ilgili muhtemel mozaiklik çok daha kapsamlı çalışmaların yapılmasını gerektiriyor. Bu çalışmalar bize şunu gösteriyor. Sporadik ailelerde taşıyıcı analizi en azından iki farklı doku örneğinde gerçekleştirilmeli. Bu çalışma TÜBİTAK tarafından desteklenmiştir. İBE sayısı 118S687'dir. Teşekkür etmek istiyorum beni dinlediğiniz için. Soru var mı acaba? Araştırma sahibine. Oldukça yoğun bir çalışma olmuş. Benim bir sorum var. Tükürük numunelerini test ettiğinizi ve iki farklı sonuçla karşılaştığınızı söylediniz. Sporadik mutasyonlarda acaba bütün laboratuvarlara iki farklı numune üzerinde çalışmalarını tavsiye etmemizi öneriyor musunuz? Evet, önerirdim. Peki siz bir numunenin diğer numuneden daha hassas olduğunu tespit ettiniz mi hiç? Şu anda sadece iki hastadan DNA alabildik, açıkçası DNA örneği alabildik. O yüzden hani hassas olup olmadığını, sensitif olup olmadığını söyleyemem şu anda. Yani Bir tane numunenin çalışılması $1000, iki tanesi $2000 hasta aile açısından. Peki fenotip farklılıkları tespit ettiniz mi bu varyasyonlarda, özellikle de belli bir varyantla ilgili olarak? Bu konuşma kapsamında sadece mutasyonlara odaklandım açıkçası. Belki vardır, bilmiyorum. Çünkü o da önemli olacak diye düşünüyorum. Spesifik bir varyantla ilgili olarak fenotipte klinik bir farklılık var mı? Hastalara ve klinisyenlere yardımcı olmak açısından bu da önemli olabilir. Bu çalışmayı yazarken onu dikkate almadık ama üzerine durulabilir. Peki, teşekkürler. Başka soru var mı? Yoksa teşekkür ediyoruz. Evet, bir sonraki konuşmacımız Doktor Başak KOÇ. Kendisi bize hemofili hastalarında tekrarlayan radyosynovektominin uzun vadeli sonuçlarından bahsedecek. Çok radyosynovektomi yaptığını görüyoruz. Yani radyoaktif materyal olarak yürüyor aramızda. Şaka yapıyorum. Buyurun, söz sizin. Çok teşekkürler. Presenting long-term results of repeated radiosynovectomy in hemophiliacs. In my previous talk, I had already presented our cases of radiosynovectomy, but what is said in the literature is that this could be repeated, but there are no long-term results. So, recurrent bleeding into joints causes a vicious cycle of synovitis, hemarthrosis, and synovitis, and can result in the development of target joints and subsequent degenerative joint disease. And the radiosynovectomy using beta particle emitting radiocolloids has been effective in dramatically reducing the frequency of hemarthrosis and resolving vicious cycle. In this study, the long-term results of repeated radiosynovectomy in people with hemophilia were presented. Repeated RS was performed in 48 joints of 37 patients between January 2000 and December 2020, and number of bleeding episodes within the pre and post-treatment 6 months were documented in first and second RS. So, RS indications include clinical diagnosis of synovitis and presence of more than 3 hemorrhages in the same joint within the last 6 months. Treatment failure is defined as need for repeat RS injection. And similarly, a maximum 3 injections were performed for a single joint with a minimum of 3 to 4 months interval. In one joint, 3 injections are done at our center. Out of 37 patients, 33 were hemophilia A, 4 were hemophilia B, 32 severe, 4 moderate, and 1 mild. And 18 included elbow joints, 17 knee joints, 12 ankle joints, and 1 shoulder joint. These had RS. Out of 48 joints in primary RS, the mean bleeding 6 months pre-treatment is around 12, but 6 months after treatment, the mean is 2.25. So there was a statistically significant decrease. But after first radioactive synovectomy, the follow-up was 40.5 months, ranging from 3 to 124 months. And we had the indications for repeated synovectomy. And the second RAS was mean was 0.3 indeed. The survival rate of the second RS was 92% at 12 months and 85% at 36 months. And out of the 48 joints, in 7, third RS was required. Out of 48 radiosynovectomy cases, there were no complications that we encountered, no radiopharmaceutical leakage or radiation-induced synovitis, or no long-term side effects were observed throughout the study period. In conclusion, if bleeding cannot be controlled in hemophiliacs, even if arthroscopic synovectomy is an option, for instance, RS is an effective treatment and can be a priority option, and we can do this up to 3 times. So thinking that the first RS did not work, we shouldn't give up. It can be repeated. And the results of repeated RS are quite good. So long-term results will be definitely shared by us. Thank you very much.
Benim size sorum şu. Acaba ilk ve ikinci ve üçüncü arasındaki süre ne kadardı? En kısası 3 ay. En kısa 3 ayda yapıyoruz. Ama gördüğünüz gibi ortalama takip süresi 40 ay. Bu artan kanama nedeniyle mi yoksa ilkin başarılı olması nedeniyle mi? Başarılı olmaması nedeniyle. Kaygılı mısınız? Kaç kez tekrarlayacaksınız? En fazla 3 kez. Ondan sonra tamam mı? Sorma nedenim şu. Ben ilk radyosynovectomy P32 çalışmasına dahildim. Amerika Birleşik Devletleri'nde P32 kullanıyoruz. Hastalardan bir tanesinde lösemi gelişti. Biliyorum. Onun sonrasında artık radyosynovectomy yapmıyorsunuz. O nedenle kaç kez vereceksiniz diye sordum. Bu hastaları uzun dönemde lösemik etkiler açısından kontrol ediyor musunuz? Bu radyosynovectomy yapılan hastalarda lösemi görmedik. Sadece bir hastada 20 yıl sonra tiroid kanseri oldu ama tiroid kanserinin bununla ilişkili olup olmadığını bilmiyoruz. Sadece uyarmak istedim. Temkinli olun lütfen. Başka sorusu olan? Buyurun. Sharing these results with us, and this is a difficult study. I can appreciate that. I wonder, you measured the bleedings, but did you also evaluate the range of motion of the joint? Maybe that was not your parameter. However, as to clinical observation, what type of a difference did you see during the follow-up process or in the early period? I must say that we have several studies that have been published on this topic. In the previous studies that we have performed, we have not seen any effects of radiosynovectomy on range of motion, at least adverse effects. And there isn't any meaningful difference that is positive, as it didn't have any effect. Previously, we didn't evaluate it in this particular study. I will have a short question. After radioactive substance use, did you control for leakage? Yes. During the first week and the second week, nuclear medicine asked us to do so, but we haven't seen it so far. In this series, no. In the previous presentation, I talked about more than 500 joints. In 2 of them, there were leakages, but in the following follow-ups, they did not experience any further problems. Çok teşekkürler. Dr. Sibel KÖKSOY. Anlatılmasıyla ilgili bir sunum ve gerçek dünya kalitatif analizi. Cheers. Hello, dear participants. Today, I will be talking about a real-world qualitative analysis of the burden of hemophilia B and patient experiences. This is a study that has been performed in Canada on hemophilia B patients, and nonacog beta-pegol is a long-acting factor IX product, and these are patients who have prophylactically experienced this product. Here are my disclosures, as you might see. And hemophilia B, as you very well know, is the lack of factor 9, and it can be given as a prophylactic or on-demand basis to these patients. In Canada, hemophilia B patients are handled according to national competitive procurement processes. In April 2018, after the approval of the product, the patients started treatment with N9-GP, and there was a shift to this product. The aim of the study was to evaluate qualitatively the disease burden among patients with hemophilia B in Canada and their experiences after switching to prophylactic N9-GP. And this is as I said, qualitative study. This is a cross-sectional study at the same time, and N9-GP was used prophylactically for at least 3 months, and those patients were included in the study. And there were semi-structured interviews that were conducted from January to September 2019, and there were 9 months. So in January, and from January to September, these evaluations were concluded. And the results of the patients were evaluated through a team, and certain expressions were evaluated. In Canada, there is the Canadian Hemophilia Society, which is a patients' association, and the patients were invited to participate. Those who were interested were directly in contact with the researchers. That's how the study proceeded. And when we have a look at this study, of the 13 volunteers, 10 were found appropriate, which means in Canada, N9-GP treatment, this corresponds to nearly 10% of the patients who were receiving the treatment. Compared to their previous treatment regimens, when patients shifted to N9-GP, the yearly infusions, especially in the bleedings, there was a reduction from 10 to 1.5 infusions. And all the patients that were evaluated here had previous hemarthrosis and decreased quality of life that they mentioned. And the details of the quality of life are also related to physical functioning, daily life activities, self-care related activities, social life, and emotional well-being. Those were the dimensions that were considered for evaluation. Here you see the results after N9-GP prophylaxis. And in fact, N9-GP prophylaxis, all the results were better, and the biggest advantage was the decreased number of infusions and decreased spontaneous bleedings. And nearly all the patients had a better, more positive experience, and they reported an increased self-confidence. Here you see the striking expressions of some patients. One of these is, if I hadn't received N9-GP, I would have had injuries because I'm a tennis player. Another patient is happy to say that there were no bleeding episodes, and another patient mentions not needing to go to the hospital. This is in fact very nice. And if somebody told me that I had to do 2 infusions per week, I wouldn't have done it, but now I can easily use it once a week, and I am very happy with this. And one patient says, I'm very thankful. I don't see myself any different from other individuals. I see myself normal. Whatever they can do in their daily lives, after receiving this treatment, I can do the same things. he says. When we have a look at all the expressions, which is for more than 50% of the patients, there were common themes that were expressed with open-ended questions. They all felt themselves more powerful, more stronger in controlling their own lives, boosting their self-esteem. This is possibly due to the number of decreased infusions and also reduced spontaneous bleedings. When the patients were asked with questions about their emotional well-being and how well they were, all of them said that their well-being was positively affected. So in conclusion, this study was a study that was conducted in adult male patients in Canada. They received N9-GP in a prophylactic manner, and the bleeding rates decreased. And this was independent of the previous treatment they received, whether it be a standard half-life or a long half-life. After shifting to N9-GP, all the patients had better experiences, as they expressed. And N9-GP has contributions to quality of life improvements. This relates to its extended half-life. And when prompted, patients confirmed that they felt more in control of their lives and more confident after switching to N9-GP, and their emotional well-being increase. The results of this study are reported in the CBDR. This is the Bleeding Disorders Registry of Canada. Thank you very much for listening. Thanks. We would like to thank Dr. Sibel KÖKSOY. I will ask two questions myself. The first one, this study is a quality of life study, but concerning the patient's compliance to treatment, is there any data? Or regarding the increase in compliance, was there a question that was asked to the patients? Thank you very much, Professor. Compliance was not questioned in this study, and that wasn't checked. That's all I know about this study. And the second one, concerning the previous patients, these were, there are two patients who had mild to moderate hemophilia. Why were these patients included together with severe hemophilia patients? Because during inclusion, they were evaluated as patients receiving N9-GP patients. So 8 of them were severe patients, but I don't know the other details. But these patients were receiving prophylaxis beforehand, but there was a switch that resulted in using this compound. Birisi kullanılmış mı acaba? Bu verilere sahip misiniz? Çünkü bunlar hastaların rapor ettiği açıklamalar. Gerçek objektif ölçümleriniz var mı iyileşmiş yaşam kalitesiyle ilgili? Sorunuz için öncelikle teşekkür ederim. Bu sadece hasta tarafından rapor edilen sonuçların olduğu bir çalışma. Bunlar mülakat şeklinde, söyleşiler şeklinde gerçekleştirilmiş. Onlar tematik olarak incelenmiş ve sonrasında ortak konular ele alınmış. Gerçek anlamda bir sonuçların gözlendiği bir çalışma olmamış. Amacı bu değilmiş çalışmanın. Bir sorum daha olacak. Acaba bu hastaların herhangi bir antipek antikoru geliştirip geliştirmediklerine dair verimiz var mı? Kalitatif bir çalışma olduğunu söylemiştim. Ölçülmemiş, Novo Nordisk olarak herhangi bir belirlenmiş inhibitör olmadığını söyleyebilirim size ama. Questions online either. So with Prasad Metu, we were co-chairs in this oral presentation session. We have to close now. I would like to thank Prasad Metu and our speakers. I hope you will have an enjoyable evening. Hope to see you tomorrow.